Okay, so now we're going to talk about assessing the patient for mobility and assessing for the complications of immobility. Every patient who enters a healthcare facility or who enters your care in their own home needs a fall risk and a fall risk assessment. Falls in a facility are a major cause of injury and liability, but fall risk interventions can actually decrease mobility and result in impaired function, especially for elders. Long-term care facilities are moving toward ways to decrease the damage of a fall rather than trying to prevent all falls. So we're really we have this tension between two risks, the risk of the fall or the risk of decreasing mobility. The integumentary system focus on bony prominences. You're looking for signs that a wound is beginning. Remember, non-blanchable redness or erythema is stage 1. Watch for those stage 1 ulcers before they become stage 2, and look for deep tissue injury. Deep tissue injury I've seen most often on heels, and heels is a place that we forget to look when we're assessing that patient. The respiratory system, listen to lungs, listen in the back, and listen at the periphery of the lungs. Please do not be the nurse that never takes your stethoscope off your neck. Please do not be the nurse that listens to 2 places on the front of the chest, the anterior chest, and calls that auscultating lungs. You need to listen to the posterior lungs and the basis for every patient. Also, what we're listening for is crackles and diminished breath sounds. I have actually had patients who had crackles, diminished breath sounds, and a low-grade fever, have them doing incentive spirometry every hour all day long and turn that around before they develop pneumonia. Basic nursing care saves lives, and this is basic nursing care. Okay. Also monitor for temperature, because if they're starting to get some infection in those secretions that are sitting, they'll start out with a low-grade temperature often before they really spike a fever. And at that point, you can intervene with pulmonary hygiene. Cardiovascular assessment. We want to assess peripheral pulses. We want to assess for edema. Definitely assess for redness, tenderness, and warmth in lower extremities, and edema that is more on one side than the other. Those are major signs of DVT. Homan sign was done for a really long time to evaluate for DVT. It's not super specific or accurate. And there's a theoretical risk that you could dislodge a clot. So some facilities don't allow Homan sign anymore. With Homan sign, you hold a person's foot hold a person's lower extremity, you flex their foot really quickly and sharply upward. And if they have pain, that's considered a positive Homan sign and may be related to a DVT. Again, some facilities have actually taken that off of the list of allowed assessments because of the potential risk of dislodging a clot that's there. If you have concerns about a clot, you can measure calf circumference and compare it to the other calf. You can also compare it to previous measurements if that has been done. So we're assessing for DVT. Again, every single patient who is immobilized needs to be assessed for DVT. Tilt test would be used to determine whether the patient has an increase in pulse or decrease in blood pressure when changing positions. Usually that's done. We might, in a regular facility, have them lying down and then sitting and then standing. And we may, if we see a drop in blood pressure or an increase in pulse, that indicates autonomic instability. Their autonomic system is not constricting their lower extremities quickly enough. Tilt test may be done on a tilt table by a cardiologist also. Metabolic, we want to look at height, weight, and BMI. We want to look at I&O, look at food intake, monitor electrolytes, protein, and BUN. Remember that we can have weight gain because of immobility if they're taking in the same number of calories as before they lost mobility, or we can have weight loss because they have muscle wasting. Elimination, we want to monitor I&O, make sure that what's going in is coming out, and we want to monitor the bowel pattern. Musculoskeletal, again, we look for weight gain or loss, look at muscle tone and mass, and we want to monitor joint mobility, assess how mobile those joints are. Neurologic and psychologic, we want to keep an eye on that patient's emotional status. Are they showing signs of depression or anxiety? We want to assess their mental status because cognitive decline can happen when someone is not able to get out and move around and have interaction with others. We want to monitor sensory status. Do they have good sensation? How's their vision, hearing, etc. We want to monitor for family support and social interaction, which can help offset some of the risk of immobility. We want to assess their coping skills and sleeping changes. Patients who are not moving around may begin to have more trouble sleeping, so we want to assess for sleep changes as well. Developmental, for kids, we want to assess their milestones. Are they meeting those milestones? Are they getting the social interaction that they need? For adults, we want to assess their level of dependence. Are they able to function as independently as their condition allows? Or are there other supports that we can give to allow better independence and also social interaction? In the next few sections, we're going to break down potential complications and how to prevent them by system.